Hello and welcome to the topic Acute Cholecystitis in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define acute cholecystitis, outline the etiology and pathophysiology of acute cholecystitis, describe the clinical manifestations of acute cholecystitis, discuss the investigations which can be carried out for the assessment of acute cholecystitis, discuss the principles of management, and finally recognize gallstone-related disorders. Let's get started. So what is acute cholecystitis? The term acute cholecystitis is derived from the Greek term called cholecyst, which means gallbladder, and itis, meaning inflammation. Cholecystitis is the inflammation of the gallbladder that occurs most commonly because of an obstruction of a cystic duct by the gallstones arising from the gallbladder itself, which is known as cholelithiasis. Before we dive into the pathophysiology of acute cholecystitis, let's quickly recap the function of the gallbladder. It functions to store and concentrate bile, which is excreted into the gut to break down fat and further facilitate food digestion. Any form of obstruction to the excretory tract or stagnation of bile within the gallbladder can trigger inflammation in the gallbladder. Acute cholecystitis occurs as a result of inflammation of the gallbladder wall, usually because of obstruction of the cystic duct. In 90% of cases, acute cholecystitis is initiated by the impaction of a calculus in the neck of the gallbladder or in the cystic duct. Majority of the cases of cholecystitis involve stones in the gallbladder, and this is called calculus cholecystitis, with the remaining minor portion of cases representing acalculous cholecystitis. Acute acalculous cholecystitis represents the inflammation of the gallbladder in the absence of gallbladder calculi. Acute acalculous cholecystitis occurs more commonly in children and adults who are critically ill or in those who have recently undergone the stress of severe trauma, burns, or major surgery. Other causes of acalculous cholecystitis include cardiac events such as myocardial infarction, sickle cell disease, salmonella infections, diabetes, and those patients with advanced retroviral disease who are immunocompromised and have opportunistic infections. The mechanism behind acalculous cholecystitis is still unclear. However, it is believed to be the injury that may be the result of retained concentrated bile that leads to an extreme inflammation of the gallbladder. The classical symptoms are colicky right upper abdominal pain that occurs postprandially. The symptoms are usually worst following a fatty meal when cholecystokinin levels are highest and gallbladder contraction is maximum. There might be also signs of peritoneal irritation, which might be present, and in some patients, the pain may radiate to the right shoulder or scapula. Frequently, the pain begins in the epigastric region and then localizes to the right upper quadrant. Nausea and vomiting are generally present, and patients may report fever as well. The physical examination may reveal fever, tachycardia, and tenderness of the right upper quadrant or the epigastric region, often with guarding or rebound tenderness. There would be palpable gallbladder or fullness in the right upper quadrant, however, that's only present in 30 to 40% of cases. Jaundice may be noted in approximately about 15 to 20% of cases. The absence of physical signs does not rule out the diagnosis of cholecystitis. Many patients present with diffuse epigastric pain without localization to the right upper quadrant. Patients with chronic cholecystitis, however, frequently do not have a palpable right upper quadrant mass secondary to fibrosis involving the gallbladder. Elderly patients and patients with diabetes most of the time have atypical presentations, including the absence of fever and localized tenderness with only vague symptoms. Here you will frequently encounter the term Murphy's sign. Murphy's sign is the maximal abdominal tenderness from pressure during palpation or examination over the right upper quadrant. It is a sign of local inflammation around the gallbladder along with right upper quadrant pain, tenderness, and or a mass. Lab investigations are done to confirm inflammatory markers. Raised inflammatory markers indicate infection or inflammation of the gallbladder and are a guide to the severity of the inflammation. So, what are the signs of inflammation that you'd be expecting to see? Of course, elevated white cell counts, elevated C reactive protein, and elevated erythrocyte sedimentation rate. Bilirubin and alkaline phosphatase assays are used to evaluate for the presence of common bile duct obstruction. Amylase or lipase assays are used to evaluate for the presence of pancreatitis. Take note, amylase may also be elevated mildly in cholecystitis. A urine analysis can be carried out to help rule out pyelonephritis and renal calculi, which may also present with similar vague symptoms. Now let's look at the various imaging modalities available which can assist in the diagnosis and management of acute cholecystitis. The simplest of all is radiography or an X-ray. Generally, gallstones may be visualized on non-contrast radiography in about 10 to 15% of cases. This finding only indicates cholecystitis with or without active cholecystitis. The most preferred imaging study is an ultrasonogram. It is 90 to 95% sensitive in the detection of cholecystitis. Ultrasound findings that are suggestive of acute cholecystitis include pericholecystic fluid collection, gallbladder wall thickening greater than 4 mm, and sonographic Murphy's sign. The presence of gallstones also help to confirm the diagnosis. Next is a CT scan or an MRI. Apart from providing us the specific findings of cholecystitis, CT scans and MRIs are useful for viewing the surrounding structures if the diagnosis is uncertain. Findings suggestive of cholecystitis on a CT scan or MRI include wall thickening more than 4 mm, pericholecystic fluid, subserosal edema, intramural gas, and sloughed mucosa. The treatment of cholecystitis depends on the severity of the condition and the presence or absence of complications. Uncomplicated cases can often be treated on an outpatient basis. However, complicated cases may necessitate a surgical approach. In patients who are unstable, percutaneous transhepatic cholecystotomy drainage may be appropriate. Antibiotics may be given to manage infection. Definitive therapy involves cholecystectomy or placement of a drainage device. Therefore, consultation with a surgeon is warranted. As for initial therapy and antibiotics treatment in acute cholecystitis, this includes bowel rest, intravenous hydration, correcting the electrolyte abnormalities, analgesia, and intravenous antibiotics. For mild cases of acute cholecystitis, antibiotic therapy with a single broad-spectrum antibiotics is adequate. Some options include the current Sanford Guide recommendations, which include intravenous piperacillin-tazobactam or ampicillin-sulbactam or meropenem in severe cases. Alternative regimens include a third-generation cephalosporins plus metronidazole. Surgical and interventional procedures used to treat cholecystitis include laparoscopic cholecystectomy, percutaneous drainage, ERCP, endoscopic ultrasound-guided transmural cholecystotomy, and endoscopic gallbladder drainage. Laparoscopic cholecystectomy is a standard of care for the surgical treatment of cholecystitis. Studies have indicated that early laparoscopic cholecystectomy resulted in shorter total hospital stays with no significant difference in the conversion rates or complications. As for percutaneous drainage, this is reserved for patients at high surgical risk. Placement of a sonographically guided percutaneous transhepatic cholecystotomy drainage tube coupled with the administration of antibiotics may provide definitive therapy. An endoscopic approach may be used for therapeutic purposes as well as for diagnostics. ERCP allows the visualization of the anatomy and can provide therapy by removing stones from the common bile duct. An endoscopic ultrasound-guided transmural cholecystotomy, on the other hand, is this procedure which may be safe as an initial or interim or definitive treatment for patients with severe acute cholecystitis who are at high operative risk for immediate cholecystectomy. Now, as we approach the end of this topic, it is useful to also recognize gallstones-related disorders. Biliary colic. The features of this condition is one having colicky abdominal pain, worst postprandially, and worst after fatty foods. The management would be laparoscopic cholecystectomy if imaging shows gallstones with compatible history. Next would be gallbladder abscesses. And usually you would expect to have prodromal illnesses with right upper quadrant pain. There would be swinging pyrexia, patient would be systemically unwell, and there won't be generalized peritonism, however. The treatment for this would be cholecystectomy and percutaneous drainage if not fit for surgery. Cholangitis, finally, comes with features of septicemia and a patient being generally unwell, jaundiced as well as a right upper quadrant pain. Management would include fluid resuscitation, broad-spectrum intravenous antibiotics, and early ERCP. Now let's recap. Acute cholecystitis is the inflammation of the gallbladder and occurs over hours. It can be largely divided into calculous and acalculous cholecystitis. Investigations are aimed at identifying the presence or absence of features suggestive of acute cholecystitis on imaging. If indicated, invasive procedures can be performed in the event biliary duct obstruction is seen or if there is recurrence of gallbladder inflammation. We have come to the end of this topic. Thank you.